Okay, good. You want to forget that. And one more thing, I'm going to make Kristen the co-host. Okay. So I just last time, for those of you that were able to come on last month on May 23rd, I was traveling. It was a little difficult and we had a lot of people on, so we didn't really do introductions. And you don't have to say much. If you can just say like what facility, and if you want one person from your team to introduce all of you, or you each want to introduce yourself, that's fine too. I just want to give Natalie an idea of where everyone's from. So besides your facility name, maybe say the village or city or town or where you are as well. That'd be great. You can even say what temperature it is today if you want, so we can see how different it is around the state. But let's start with, let's see, how about, Dina, do you want to start? You're on mute. Oh,
sorry.
No
I was just trying to click and my laptop wasn't being nice to me.
No
it was
worries.
making me work. My name is Dina Jackson. I work for Bristol Bay Area Health Corporation, which includes Kanakanak Hospital. And I want to say welcome to Kristen McLean also. I think this is the first meeting I've been on that she's here. So welcome. Glad that they were able to find you. It is 61 degrees today in Dillingham and mostly cloudy.
Great, thanks, Dina. And yeah, thank you. I should have said that first. Kristen, so everyone, I think everyone on here knows me here at AHA. And Lynn had left to go to Bristol Bay. And we just, Kristen started yesterday, but she's been involved with the collaborative and in the past. But yeah, Kristen, if you want to just do a quick say hi or introduce yourself, that'd be great.
Sure. I'm Kristen McLean. You might formerly know me from Providence and Seward. I was there for 16 years, but now I'm moving over to working with AHA, and I'm spending my first week in Juneau this week. But I'll be back to Seward at the end of the week. But I'm excited to see this side of the work and work with all of you directly on this project. And according to my phone, it's 58 degrees here today in Juneau. 40 and raining in Seward yesterday, so I'm glad I'm in Juneau.
Yeah, well, great. We're so happy you're here. And actually, the Flex team is on, I see now. Do you guys want to do a quick, Erin and Kate, introduce yourselves?
Yeah, sure. Hi, I'm Erin. I'm with Mountain Pacific. I know I've talked with quite a few of you, mostly related to the directly reporting for MB Quip. And yeah, happy to be here.
Great, thanks, Erin.
Hey, I am Katie Harmon with the state on the Flex team. And if we are reporting the weather, it is muggy and rainy and 58 degrees.
Great, thanks, Kate. So how about, we have a great group from Manilik. Helen, you want to go first? And don't forget to talk about your picture.
My picture, okay. If I can get it unmuted. Yes, my name is Helen Linderman. I work in quality at Manilik, and it is 38 and cloudy today here. And my picture, let me close this. For those nurses, this is from a trip. For those of us who are nurses, I went on a river cruise last year and had an extension in Istanbul. And that building was used to be the hospital that Florence Nightingale worked at during the Crimean War. So that's what it's my background.
Great, thanks, Helen.
Welcome.
So the rest of you guys from Manilik, Heather and Shelley, and then Monica.
I'm Heather Kennison. I'm an inpatient nurse case manager. And Shelley Nordlum is the acute care manager for the unit here at Manilik. And we're about 37 degrees and no end in sight. Warm weather, it would be nice to see.
Yeah, at least it's not snowing, we were saying before, right? So, oh, great, Monica, there you go.
Hi, good afternoon. I'm Monica Garcia. I'm work in the quality department here at Manilik and Kotzebue, and Helen already gave us the weather report today. So
Yeah.
thank
Great,
you.
thanks, Monica. How about from Ketchikan?
Hi, I'm Louis Scott. I work down here in Ketchikan at Peace Health Medical Center. Work in the quality department. I'm fairly new to the position, and happy to be here. Oh, and it's about 55 degrees here.
Great, thanks, Louis. And Juno Bartlett?
Hi there. I will do our introductions. I don't know if anyone's here besides Deb. I didn't see on all
I
of
think
them.
I think just
Okay.
you. Yeah.
I'm Jeanette Lacey. I'm the Director of Case Management at Bartlett and Juneau. And Deb Kelsch is on, and she is with our quality department. So we work closely together on the projects that we're doing. And as I mentioned already, we have Addie here with us from Boise State, but also originally from Juneau. So we're glad to have her with us too.
Great.
It's around 60 degrees, I think.
Yeah.
It's been warm.
It looks like it's getting warmer and warmer as the day goes on. So let's see. Great, Chris, great to see you from Fairbanks. Do you want to introduce yourself?
Hello, everyone. I'm Chris Lunny. Some of you know me, some of you do not. Happy solstice, everyone. Today in Fairbanks, we look forward to our Gold Painters game, which happens at midnight. And so that's always a ton of fun. That first pitch goes out very late. I myself am not a huge baseball fan, and I am an early bedtime fan. So I'm kind of a party pooper when it comes to actually going to that Gold Painters game. You won't see me there, but the weather should be nice. Hopefully for them, it's very cloudy outside, looking at 66 degrees today, but the sun is intermittent. So hopefully just long enough for everyone to get out, do their barbecues and all that good stuff. So thanks for letting us eavesdrop on the group. My facility is still deciding if they are going to participate in full. Thank you.
Yeah, great. Thanks, Chris. And we're going to talk more about the participation and all of that in a few minutes. So, and then Amy, I think Amy from South Bend, great to see you on.
Hello, I'm Amy Wyrick, and my director Jane had asked me to fill in. I work in the utilization management department, and I'm new in this department. So I'm gonna eat lunch and listen. And it's 50 and rainy here.
Oh, rainy. Well, great. Thanks for being on. And just, I should have mentioned this before, but so last year we had our readmissions collaborative, and 6 of those 10 hospitals continued on. But we have a few new ones that are really interested in health equity, that piece of it, which is kind of our focus. And so we've invited everyone to join these last few calls. And then after today, in terms of commitment, we might have some different levels of commitment. We're trying to figure that out for people that want to participate but don't have, at a different level. So we'll let you guys know about that. But I'm just glad you can all be on today. And I'm going to introduce Natalie really quickly. And how this came about is, as we're working on the health equity, I saw a presentation they gave at the CMS Quality Conference about their work in Montana and California on health equity. And I was like, this is exactly what we need. And so I contacted them, and we've contracted with them to do webinars and coaching and work with us through the year. And so this is the second one. I sent out the recording from the first one if you missed it. And we'll be recording them as we go. And I think that's all. I'll turn it over to you, Natalie.
Awesome. Thank you. Hi, everyone. It's so great to meet you all and see smiling faces. I'm Natalie Graves, as Debbie mentioned. So I'm part of the Cynosure Health team. I'm based in Chicago, and I love working with states all across the country, because I think Chicago gets a bad reputation of having bad weather. But then when you talk to people in Montana, they're like, your weather's great. And then I talk to you and you're like, your weather is really, really great. So I think it's 78 degrees here, which is, we love. So let me pull up my slides. What our game plan is today. So the last session we had was the big picture, like all of the different things that our team at Cynosure Health has been doing around the idea of health equity and social drivers of health as a strategy to advance health equity. And that runs the gamut from area level analyses to supporting individual hospitals and thinking about how to do screening for social drivers of health. And so what we thought we'd do today is focus this session on that piece, on within an individual organization, how do you set up a process to learn from patients about their social drivers of health, health-related social needs, social risk factors, whatever you want to call them, the circumstances in their life outside of the healthcare system, outside of kind of a medical perspective that would influence their health outcomes. So my goals for today, if this makes sense to the group, are to think about and talk about how this screening for health-related social needs and social determinants of health can improve care transitions and reduce readmissions. So wanting to focus on that kind of tight tie between this as a strategy related to improvement around readmissions. Then we'll spend most of the time talking about how to do this, right? I'd love to really focus on like, what are the concrete steps for implementation? I'd love to learn from you on the next slide when we get in where you are in the process. Are you at the beginning? Have you already started? And then we can really customize the conversation based on what makes the most sense. And then at the end, I have some more content ideas that we've gathered over the different conversations and projects we've had with hospitals over the last year. Some really, I think, concrete ideas, kind of tips, tricks, strategies to start building a process like this. And so I'll share those and then tee up what comes next, which is hopefully having you all do some PDSA cycles and testing of these screening processes in your own organizations, and then coming back in a few months to reflect on what worked well, what might you tweak, kind of a deep dive into this data collection process. I wanted to start with a story though, because I did a big webinar on this topic earlier today. And when I think about this work and health equity and social drivers of health, I spend a lot of time thinking about it. And for me, it's really easy to spiral into, this is so big, it's so complex. What the heck is a hospital's role? How can we possibly address all of these things? And one of the things that I think really resonated in the last conversation was the idea of focusing on one patient at a time, right? We have the opportunity, if we understand patients' needs and their full situation, to improve their care one patient at a time. And we can build from that into larger systems and thinking about patterns and partnerships and programs more upstream. But for now, we're really focusing on one patient at a time. And the story I wanted to share, I heard, I was working with a hospital in Colorado. There's a woman there. It's a small, I think it's a critical access hospital in rural Colorado. And she had basically stood up this whole SDOH screening process because they saw how many of their patients were being readmitted because they had these social needs. So she set up this process, and I was talking with her about, what does it look like when it goes well, right? Tell me a success story of, why do we do this? What does it look like when it works? And she told me about a patient she had who was a husband and a father of 5. He had 5 kids at home. She was talking with him, kind of going through the screening questions through a conversation, and she asked him about food, whether or not he had enough food or could get enough food, which is, a very common question. And he said, well, I can get food. I have no problem getting food, but our refrigerator broke and I can't get a new refrigerator. So even though I can get food, I can't store anything fresh. So functionally, I have a real problem with food right now. And she said, well, let me get on the phone with this woman at this food bank I have a partnership with. She called up her partner there and she said, you know what, I think we actually have an extra fridge in the back. If he can get here and pick it up, he can have it. So he was able to go get it, he got the fridge, and then she shared that her neighbors, because they're a small community, shared with her that they saw the family, taking groceries into the house the very next day. And I thought this was such a uplifting and clear example of how important this work is. And also a good example of how complex it is, right? It's not just asking these 5 questions as they're worded and checking the box. It's really figuring out how we can have conversations with individual patients, again, about their circumstances and help them brainstorm solutions. I don't think every person who needs a fridge is going to get a fridge from the food bank, but there are lots of creative solutions and lots of resources that do exist if we can find a way to begin to have these conversations. And that's what I think this screening is all about. So I do want to get a sense of where you all are in terms of thinking about SDOH screening processes, if this is totally new, if it's top of mind, if it's not top of mind. So if you could throw in the chat, or if you want to come off mute and say, share with the group, what are you currently doing in this area of screening for and addressing social drivers of health? And then what burning questions do you have, or what's top of mind for you? What are you kind of thinking about most importantly as it relates to this right now? And that will help direct the conversation. And it's okay if you say, I'm not thinking about this at all.
This is Amy Wire calling from South Peninsula. And like I said, I'm new to this position, but one of the things that I'd like to work on is our intake questions. And exactly, it's not very robust. So I don't know if people can share maybe some of the different intake questions with discharge planning, or like you said, with any issues that patients are having.
Got it. Are you, when you are thinking about that, are you also thinking about collecting demographic data? I know that's something that sometimes comes up. Is that something you're thinking about too, or not necessarily?
Personally, I wasn't thinking about that, but I know that there was Mike Tupper was in the role of quality, and he actually has taken a different role. So I'm not sure where we're at with that, but that's something that I can pass along.
Okay, so you're thinking more about questions that inform discharge planning, so kind of upfront.
Yes.
Okay, that's helpful. Okay, thank you. And then I see Jeanette said you've built a tool in the EMR, getting some of them done. Difficult part is consistency. Okay, so kind of like a scaling of what you've already tested.
This is Helen at Manilic. We found that one of our partners in our THO had developed a form in our Cerner that drops the Z codes when you fill it out. So we just recently have access to it, and we're starting to train nurses. And so that's where we're at in our process.
Awesome. All right. THO. Okay, excellent. Thank you for that, Kate. Dina says this is new, not collecting data. Tool has been created and the process specific to the region. Great. Love to use a form, but not how to integrate into EMR. Okay. These are great. Great questions. So it sounds like a mix of some beginning implementation, probably lots of lessons about what might work well, what might not, and also folks really at the beginning. So I think the conversation will be helpful today, hopefully for everyone. Chime in along the way in the chat, or just come off mute too. I'll pause, but this is really meant to be a way to start to collaborate and share ideas. Let's go ahead and actually just answer Chris's question. So for those of you who are using a form, how long does it take? And are you sending it to patients via a portal to be filled out ahead of time? Can anybody speak to that?
Right now with our Cerner, it lives in our ad hoc forms, and we are filling it. I don't think we have actually filled it out with anybody since we're just training on it. Just looking at it and stuff and going through it, it takes about 5 minutes. And I don't know, I haven't heard that we've sent anything through our portal to be sent filled out ahead of time by anybody. So I don't know about that functionality of the form. It's based on the prepare form. So that's what we have.
Great. Okay, excellent. So this also raises a couple of different nuances, I think. So a lot of the work that we have done has been around hospitals who are setting up inpatient screening processes to be ready to report on these CMS measures that are mandated beginning in 2024 for IPPS hospitals. So I know that's not applicable to a lot of you, but I do believe, and maybe the Flex team folks on the phone know this better than I do, or have more intel, that these SDOH screening measures are part of the recommended measures for the MBQIP program. So even if these inpatient screening measures are not applicable to you in the moment, they probably are coming to a place near you soon. So we can talk from an inpatient perspective on screening processes. And then also, I suspect many of you have like rural health clinics or outpatient or primary care work that you might be tangentially related to or closely related to. And there's also a lot of screening going on in those settings. And so I think one important consideration is there might be different approaches in different settings. That's something we hear a lot from hospitals or from folks that we're talking with. Chris, I see your hand.
Hi, yes, Natalie. I have a quick question. I'm looking at your slide here and I see number of adult inpatients screened for all 5 non-medical health-related social needs. Is that the specific requirement? The reason I'm asking is because I am currently working in our cancer program, and they're finding that sometimes we have head and neck and esophageal patients that we don't know ahead of time that are going to be having surgeries or tube feedings placed. And we're working to improve the tube feeding for our rat-onc patients so that we can get dietitian consults before they have those interventions put in place so that they can be prepared and be better ready to have the supplements and all of the equipment they need and the knowledge on hand versus find out 2 weeks later that they've gone 2 weeks without supplementation or food. Is this an outlier for this type of work? Or is this actually the type of work we're looking to do?
That's a great question, an example. So I just dropped the measure specifications in. They're pretty vague. So there are, I'm going to try to answer your question, but I might not hit it. So let me know. So the CMS measure is to screen all inpatients for these 5 domains. It's housing instability, food insecurity, difficulty paying utilities, difficulty with transportation and interpersonal violence. There are exclusions for patients who, for whatever reason, can't answer the questions or it's not really appropriate to do the screening. So I don't know if that's kind of all we know in terms of the requirement of these measures. It seems like there's probably application to the example you're describing, but I'm not sure if I'm getting at your specific question.
Sure. So if we have an inpatient or a patient that's scheduled for surgery to have a tube feeding placed because of they're also having some sort of invasive surgery to their esophagus, that is a medically created condition, right? Their cancer or the surgery has created that need for that tube feed. Does that mean that it's no longer a social need for that supplementation and that food and that education, because we're finding we may have a gap and we're going to do a project around that. We're definitely looking at the outpatient setting, but I think that we have some inpatients that we could measure that is, as we begin to work with them proactively, that maybe our project would fit into this box or maybe it doesn't. It may not, since it's medically created necessity versus socially created necessity.
Yeah, it sounds like it's certainly related. So presumably you would screen those patients for these different needs and they may say, I don't have food insecurity, but you may recognize that they may have implications based on the treatment, I think is what you're describing. And so you're going to
right, because they may not have the ability to afford expensive supplementation for their tube feedings when they do have food stamps, but maybe the food stamps don't support food, tube feeding. So then they have that nutritional need. So that, does it then become a social need? Or if we use that to meet our criteria for the first couple of years, or would we still be in need of other projects, do you think?
Yeah, I think this is a great example because it really speaks to the nuance around it, right? So I think it depends how you want to define it. If you want to say, we screen, we have a conversation about the implication, you might end up saying, coming to an agreement with the patient and saying, and, talking this through with them and explaining, we see this as like a positive screen, and this is what we're going to do to support you. So that would show up in your data as, yes, screening positive for food insecurity. I think that's fine. It's reflective of your approach and the interventions you're taking. So I wouldn't be concerned about like social versus medically induced, because I think it all is wrapped up together. Does that
Sure.
help?
And if it does start going well, and the nurses are finding that, gosh, this doesn't take long to ask these questions for these patients. Why are we not asking it for everyone? Maybe it will spread like a wildfire. That would be really cool.
Yeah.
So we'll just have to wait to see, but thank you for giving me a few minutes.
Yeah, absolutely. So great question. So this is the first measure is the screening rate. So the percent of patients who are screened for these 5 domains. The second measure that will be required is the percent of patients who screen positive for each of those 5 domains. So, and this is reported as 5 different rates, actually. So the number of patients who screen positive for food insecurity over the number of total patients screened, number who screen positive for housing instability, et cetera. So the question is, how do we set up processes to do this systematically, sustainably? How do we figure out what resources to devote to build these systems, to have conversations with patients, document and use that information to inform their care plans, and then ideally down the line, document the information in a way that leads to an ability to analyze over time. And so once we have a larger data set, we can start to say, are there patterns in where we see patients who have food insecurity, or is there a particular neighborhood or area where we see patients who say they have housing instability? Is there a part of the state that seems to have greater need in any one of those things? And so part of thinking about setting up these processes is not only the one patient at a time approach, which is extremely important, thinking about how you actually have those conversations and do the screening and then connect patients to resources, but also how you can set yourself up for success in the long run, again, by thinking about those kind of systems and processes that you want to invest in. So I use this slide in all of my presentations on this, both because I think the little boy is very cute, but this work, I think, involves 2 important things. One, it's a missing piece of the puzzle, right? We've been doing work for years in thinking about how do we reduce readmissions, how do we put together community health needs assessments and implementation plans, how do we think about prevention? There's a lot of work that's been kind of swirling in this space. And the addition of thinking about screening individuals for their individual social needs, and then building that up to a hospital level understanding of needs across your population, that's a different way of looking at and understanding the challenges that your specific patient population faces. So it's kind of a missing piece of the puzzle that you can think about as you look across the efforts you already have in this space related to equity or reducing readmissions or thinking about prevention. How can you tie in this new data source? What new information does it give you? And then the second thing is that it takes new muscles. It takes a different way of thinking and a different way of acting and staffing and supporting to address things like social drivers of health, right? Our systems are not necessarily set up to do that. We're not necessarily staffed to do that. Some organizations have the right kind of staff, but not all of them do. And so this will require thinking differently. And there are inevitably going to be growing pains. But I think that's part of this process, is being open to thinking differently about the work, learning certainly along the way, and adjusting as we go along. So what I thought we'd do today is start to think through the 5 whys of SDOH screening. We have learned, as I said, a lot from organizations who are testing out different things. So I have some things I can share, and would love to just exchange ideas with the group and kind of get out what your questions are, and start to begin that dialogue as you're thinking about setting up these systems and processes. I like the 5 whys, or the 5 W's plus the how framework, because it just raises all the questions, right? You get all the questions out there, and then you can start to think about how to organize. But I find that it's a good way to consider all the components before making any decisions, so that you can be a little more strategic in designing programs. So the first one to think about is Oh, and then the piece that underlies all of this, which I think is really key, and something that comes up a lot in conversations is, yes, you have all of these logistical process, data-oriented components, but at the end of the day, it is about that one-to-one patient interaction. And how do you build trust with the patients you're communicating with? On the medical side, certainly, but this is kind of a whole new ballgame in terms of talking about potentially sensitive and challenging barriers that people face. It's often the first time we've had these kinds of conversations in a healthcare setting or in any setting. So there's a lot of intentionality that can go into building a system in a way that promotes trust. So the first question is who? A couple of questions here to think through, and I'm curious to get if you've already figured out your answers or you have approaches that you'd be willing to share. The first question, who are you screening? So again, the CMS measures ask for you to report on the percent of all inpatients screened. I think that doesn't mean you have to screen everyone, right? You can start small, you can start with a priority group. You might never ultimately screen everyone. But we have heard from other organizations that it can be useful to start small, right? You can start with a designated group, maybe based on a particular condition. We hear a lot of work in maternity care often, or you might prioritize based on some known risk factors, lots of ED visits or recent admissions, and start with a small group of patients, test out the process, finesse things a little bit before you spread it more broadly, if you decide to spread more broadly. And then the second question on the who front is who's asking the screening questions. And I think this is a huge one. We hear all sorts of different approaches. We hear a lot of people who have care managers ask these questions in the inpatient setting, sometimes nurses, sometimes social workers, sometimes medical assistants, which I didn't spell correctly. But I do hear a lot that in the inpatient setting, people do tend to find that face-to-face conversation works best, particularly if it's kind of integrated into the discharge planning process. There might be conversations already going on anyway, so it makes sense to integrate these questions into those conversations. But there are certainly people who are doing it using some kind of paper or tablet tool as well. So I'll just open it up. Are these questions you're thinking about? Have you already started to brainstorm around them, or what are you focusing on in terms of who you're screening and who's asking the questions?
This is Jeanette at Bartlett, and we, as I mentioned in the chat earlier, we have built our tool in our EMR, and it's based off of the health-related social needs. And so with the 5 domains, and then we do have some other additional drivers questions below that. We put the 5 at the top, and it's being asked right now by the social workers. They do the discharge planning, trying to get that information early. It's harder to do it on the more on the medical side, I think, mostly because of volumes of patients in general and staffing. But we're trying to do it. We're looking at, our goal is to do it for all admitted patients. Where we're having the most success is on our acute mental health unit. So our social workers do spend more time with their patients just because of the nature of how much work they do with those patients. So we have a lot of success there. We are getting some done on the medical floor, but it's a little bit harder. And then when we're working with our OB, that's where we're thinking that, a form or a tablet, and also on the medical floor too, where somebody's an inpatient, but, it seems like things like they're doing pretty well, but we still want to capture that information, because you never know, somebody who's doing really well might not. But sometimes I think works well to have that face-to-face and build that rapport and take that time. But sometimes people might feel a little bit more comfortable if they could just fill out that information without having to say it to your face. So we just wanted to have the both options available, and we don't have that yet. So I'd love to see if there's any way we could have it on a tablet or in a document, but that kind of flowed in. The only thing that we could think of would be to do a manual process, and that isn't really what we want to do, is just take somebody's answers and then hand fill it in.
Fill it in into the EHR.
Yeah, I mean, that's what you could do that, but it's not ideal. It would be preferred if there could be some way that it could just flow, but we might not be there yet.
Thank you. Super helpful. You mentioned the social workers are asking the questions. Can you say a little bit more about when? Like, is it early in the admission process? Or, so I think that's an important question too that folks sometimes wrestle with.
Yeah, I think, that's maybe why we're not getting it as much on the medical side too. I mean, I think it really depends on the patient. I think sometimes it takes longer to build rapport. So I think you need to kind of need to work that out. So discharge planning starts on admission, right? So as you start talking with that patient about what their transition plan is going to be as soon as they get here, and you start trying to pick up some of that information. I think it works best, honestly, if you don't try to go and, okay, number one, tell me about your housing. I think it works better to have a conversation with your patient about those things without doing it like a checklist of questions. So it's not a very direct answer, I guess. It just depends. It depends on how open that patient is with you, how much time it takes to build rapport. I would say you probably don't sit down and do it in one sitting usually, but that you're kind of gathering the information over time. So the way ours is built in the EMR is that you can go back into it and keep answering. And it's not like you have to sit down and finish that whole assessment at one sitting.
Thank you.
So, yeah, thanks. Oh, and we also attached our Z codes right to each question so that the social worker can check the Z codes and they can put their documentation in there that support the Z codes, but that way the coders can just go in, they see the documentation and they can see which Z code. So that's right there in our assessment tool.
That's great. Okay, thank you. How about others? Any questions for Jeanette or other perspectives? Okay, we'll keep rolling then. So the next question is what? And this, I think about what tool are you using? So there's a ton of tools out there. Some of the tools are very long. Some of them, probably all of them, align with the CMS requirements. There might be other requirements that you're tracking to as well, though. So if you have Joint Commission accreditation, there are some standards around SDOH screening as well. You may have other payers or other programs in your state that have different requirements that might require different questions. And so when I think about selecting a tool, it can feel daunting. I think the CMS tool that Jeanette described, I can drop that, or it's actually right here on the screen. I think you were referring to that CMS screening tool, the health related social needs screening tool. That aligns perfectly with the CMS requirement. There's a short version and a longer version. So that's I like that one. It's pretty kind of easy to work through. The Prepare tool is another popular one. This website, Siren, and we'll send these notes around, has a really great comparison table of all of the tools that exist. So you can look at them side by side and figure out which one meets your needs. You also will probably want to think about what your EMR already offers. So some have built-in forms, some have the ability to create forms, based on what you want to put in there. So thinking about both what questions you want to ask and why to align with requirements, what existing capabilities can you build on? And then also, what do you want to ask patients, right? You might want to ask them these 5 things, but you might know in your community that say, loneliness is a really big challenge. This is something we're seeing more and more about. So maybe you add a question about that, or maybe there's another need that's prevalent in your community that you want to ask about, not because it's something that CMS mandates, but because that could be a need for your patients. So it's a little bit of an art and a science. There are a lot of different resources. I think you can pick one and always tweak it, right? And also the screening tool, like Jeanette described, and we hear this a lot, it's a starting point, but it tends to work best if you don't just stand there and read the questions verbatim, right? It's a starting point to think about how you can get at conversations around these different domains. But it's just the beginning of the conversation typically. So any other, let's see, here we go. Jeanette, thanks for putting that in, that you are using the AHC tool, but modified it a little bit. Use the prepare tool before and then aligned with the CMS requirements. So that's helpful. Anybody else using a given tool that works well for them, or thinking about kind of trying to decide between a couple different tools? How many of you, if you still need to select a tool, can you raise your hand? I won't call on you. I'm just curious how many people are in the tool selection phase, or if you already have something. Looks like most people are beyond the what question. Okay, helpful. All right. So next is kind of the more practical of when and where do you ask the questions? And this goes with when and where and how. And we've started to talk about this already. So just throwing out a few considerations again that we've heard along throughout these conversations. There are pros and cons to all of these approaches. I think the main message is it depends. It can depend within an inpatient setting. As Jeanette described, it certainly can depend in inpatient versus outpatient. So it can be helpful to think through different approaches. We hear folks sometimes ask if it makes sense to ask during registration. That doesn't work sometimes because of staff comfort. So if you think about the team who are asking the questions, they might not be equipped or comfortable asking these kinds of sensitive questions, right? If they're used to asking about things like the normal registration details, insurance information, if all of a sudden they have to tackle these heavy questions about really serious social needs, that might not be a good fit. It also might be uncomfortable for patients, right? If they're being asked these questions in the waiting room with other people around as they're coming in, that just might not be a good fit for anyone. In the room, so once the patient is back in the room, either on admission or part of discharge planning process, seems to be the way that people tend to have the most success in integrating it into those other conversations and processes. Paper and electronic, like we talked about, some folks, I see more of that in the outpatient and primary care setting, but again, there may be cases where it makes sense in an inpatient setting too, for particular conditions or the like. I think one big takeaway here that I want to highlight, and I have another slide on, is this is a great opportunity to work with patient and family advisors to design this part of the process. So I don't know how many of you have like patient family advisory councils or experience working with patient advisors around quality improvement projects, but this to me seems like such a ripe opportunity to engage patients in the design of this work, because it is all about building that trust and creating an approach and a way of talking that is very patient-centered so that you can get the information that you need to provide support. So this is just an example slide from our partners at an organization called PFCC Partners, that demonstrates how adding in patient and family partner perspective, whether that's through an existing patient family advisory council structure or otherwise bringing patients and families into the design process, how that can help you be more effective and more efficient. More efficient because they'll help you identify the issues faster, and you won't spend too much time doing something that is having unintended consequences or not meeting the true needs of patients if you get their feedback early and often in the process. So on the left-hand side of the screen, or the blue, is kind of a typical process you might go about of using data, developing your program, doing everything internally, and then pushing it out. On the other side with the green are some examples of where patients and families can have valuable input along the way. So you start at the same point of using data to figure out where to start, but then you bring patients and families in to validate that data. Say, does this resonate with your experience? What are we missing? What nuance could you add? What does resonate? Where is the data really telling the true story? Patients and families also know about the resources that exist in the community. So that's a very efficient way to learn Where do you go if you need food? Are these food banks open on Mondays and Tuesdays and only the third Thursday? Or are they open for all the hours that are on their website? There are probably resources that exist that are excellent that don't show up if you just try to Google what's available. So talking with patients about what exists in the community is a great way to build your resource lists. And they can also be very helpful in co-designing around things like messaging to talk to patients about why you're asking these questions and how you'll use the information, and also informing the process of how does someone come in, what is it like to go through that experience of being asked these questions, getting the information, and again, really designed in a way that's focused on understanding and meeting the patient's needs. Anybody working with patients and families through a PFAC or otherwise around this work, or have questions about this? Does this seem like something you would consider? Any reactions to this?
Natalie, this is Deb Kelch from Bartlett. So, you know, we have been meeting, we have a PFAC group that's been meeting, gosh, I think the better half of a year now, maybe. Anyway, one of my coworkers is running that, and she actually sits next to me at a different desk. And so we've been doing a lot of talking about, you know, kind of the new requirements for collecting, like the social drivers of health, and then like her work in with the PFAC committee meeting, and kind of how we can essentially just combine and join, you know, kind of what has been two separate kind of initiatives at the hospital, and trying to see how we can kind of align them together. So we're kind of at the beginning stages of that. And I just kind of, I guess that's kind of what we're hoping to do in the near future, as far as like bringing in family members and patients, and just kind of getting a feel for even like our new questionnaire that we'd like to, you know, bring up with our inpatients and everything. So just to let you know, we're kind of looking at incorporating that with our PFAC in our PFAC, you know, so it's just kind of one and the same, I guess. Yeah, so.
That's great. So I'm gonna write your name down and ask you in 2 months how that's going, for sure. I can't wait
Yeah,
to hear.
definitely.
Yeah, that sounds excellent. We'll be very curious to hear about that. Cool. Okay, I know we're running a little short on time. So last bubble here, arguably I should have started with this question, because I think the most important W is why. Why are you setting up this process? And I think, you know, it's important to figure out why you're doing this, to set your vision for what you hope to achieve by asking these questions, because the process that you set up, the staff, the reporting capabilities, the infrastructure that you invest in will be based on what your vision is, right? If you have a very narrow idea of screening individual patients and addressing their needs in the moment, that might be fine. It's a narrower scope. If you have an expansive vision of how you can build up this information over time and integrate it with other data sources, that's going to require a very different approach. So I think figuring out what your vision is for the work will help guide your decision-making and implementation as you go ahead. It's also important to reflect on why we're doing this. I think we can get wrapped up in we're doing it because it's required, or we're doing it because we know it's good, but we don't exactly know why or how to articulate why. But as you go through this process, you'll have to explain why to a number of people. You'll have to explain to your leadership team, if you're advocating for resources or additional time, how this fits in among a number of other priorities. You'll want to make sure you explain to your team and your staff why you're doing this. Sometimes we hear that, you know, team members don't understand why we're asking these questions and what we're doing with the information. And if I don't understand as the person asking the question, I'm not going to devote the thoughtfulness that's required to asking them, because I just don't have the context. And then finally, we hear a lot, it's really important to explain why we're asking and what we'll do with the information to patients. This is new to a lot of people. It can be jarring and confusing to all of a sudden start having these conversations that we're not used to. And so thinking about how you can explain to patients what these questions are about and what you'll do with the information, how it can help them, help you help them, is an important piece of your planning as well. And finally, I think, this is ultimately up to each organization, right? There's no one right way to do this. There's no, despite the specifications from the CMS measures, there is no set number of things you should ask about or specific things you should ask about. But this is really an opportunity to think about what new systems, what new capabilities do we want to build? How do we want to build new partnerships, new programs, new policies that over time impact these stubborn and persistent social drivers of health? And so it's up to you ultimately to figure out how you want to do that and the impact that you want to have. And again, that then will feed into the processes that you ultimately operationalize. So a couple of resources which I think might be helpful as takeaways. This is a document if you are just getting started and want a couple things to check off to begin the brainstorming. Some key first actions: set your vision, figure out what success looks like. Convene stakeholders. We typically see an all hands on deck effort, at least to start, because there are so many people who are integral to the process and whose perspectives should be included at the beginning. Over time, you can figure out and narrow who is responsible for key elements, but the key stakeholders in this work is really a lot of different people. And then identify existing resources. So in many organizations, there have been some grant projects or other projects that have tested out screening or tested out developing relationships or partnerships with external organizations to address social drivers of health. And so there may be existing resources and experience to build on and good places to start. Again, another list of, if you want to take stock of where you are in the planning process, this is a helpful set of questions to think through and try to answer and identify where might be some additional areas to focus. So things like, do your staff and providers have an understanding of why you're asking these questions? How will you explain to patients why you're asking the questions? Have you set up systems to train and provide resources to the staff members who are asking these questions? If a patient screens positive, what will you do, right? That's a huge question and opens up the door of how do you set up referrals or partnerships with external organizations who can be supports when people do screen positive? And then how do you think about analyzing data over time? We talked a little bit about this already, some tips for building trust that we've heard. And I think all of these were reiterated today. Face-to-face can be a really good strategy, especially when you have the processes and the opportunity already set up. Let patients know why you're asking. You might need to ask the question multiple ways, multiple times over multiple days, perhaps, and give context on what you're asking. So I think a lot about, somebody asked me, or if I asked my husband, who doesn't work in healthcare, do you have food insecurity? He would probably not know what I was asking, right? A lot of these questions have a lot of jargon. And so we have to find ways to ask them in a way that's meaningful to the patients. Scripting can help. A lot of people are often looking for scripting to help with asking these questions. So scripting can certainly be helpful, but so is practice, right? We hear as you get comfortable having these conversations, it becomes less about a script and more about that art of uncovering these things. And also we hear, we've talked with patients about this. It's okay if you don't have all of the answers or a clear solution. We often hear fear around the fact of, well, how can I ask this question if I don't have an answer? And I think the response to that is, if you ask a question, you don't increase the risk to the patient, right? The patient has that risk regardless, but you can begin a dialogue and a conversation around, okay, how could we brainstorm to find any even small solution, or at least have a person in your corner who they know then they can come to that's on their team to help them with these things, even if there's not a clear solution. All right, so we have 4 minutes left. Our goal here is to get to action. So we've talked a lot today about how might you set up a screening process. I'm going to assume that it is important to all of you to, in fact, continue doing this, that it's a priority to set up a screening process and keep testing. And so what I would like to ask folks to do is do a couple or one PDSA cycle over the next couple months before we meet again in August. And at the end of August, when we meet again on a date to be determined, It will be a really open-ended session. We'll ask folks to share out, what did you try, what worked, what didn't work, and we'll do some sharing of really concrete strategies that can then be shared out of what challenges do you have, and then what are some ideas on how you can address those. So we'll send this form around in a couple weeks to check in. It's really simple. Again, pick one element of your screening process, whatever makes most sense depending on where you are. Could be testing a new tool. It could be testing with that specific population, cancer population. It could be testing out something with your PFAC. Do a couple trial runs, figure out what worked and what didn't. We'll document that in this, again, really simple form. And then in the next session, we'll do some sharing out of those practices. This is what I just talked about, and that's it for today. So any final questions, considerations, we'll be in touch by email. And if you have questions that come up in the meantime, definitely don't hesitate to reach out. But I really appreciated hearing all that you're already doing and the sharing, and can't wait to see how this progresses.
Thanks, Natalie. Any last questions for her?
Natalie, this is Katie Harmon. I just had a quick question, and maybe this is too basic for where hospitals are at already, but do the tools have like sample scripts of how to talk to patients or how to introduce what you're going to be asking? Or do you know of any, I guess, that are really good?
That's a good question. I don't know off the top of my head, but I could certainly look and see if there are anything. I know the AHC website has a ton of like case studies as well. So I wonder if there's anything in those around scripting or introducing. We also have some resources that I'll share around. A couple organizations have shared some text that they use to introduce to patients why they're asking. So I can share those as well.
That would be great. Thank you.
This is Jeanette. The AHC, it kind of gives some like examples of, so instead of just saying, you know, do you have food insecurity? It says, you know, it asks like, were you worried that food would run out before you had money to buy more? So it makes the questions more relatable, and it kind of gives, so with housing, like if you have substandard housing, what does that mean, right? So it does have some things like, you know, that might trigger some thoughts of that, like there's mold or there's lack of heat or the stove doesn't work. So that kind of gives you some things to check in with them about to sort of make that more relatable.
Great, thanks, Jeanette. And also, we have a website where we're gonna not only gonna email everyone out, but we're gonna put all these resources on. We'll put the link she was talking about, all those items, so that you can go back to them. You don't have to look through your email. And one thing I found, and it's on that website that we've created, is how to explain to the patients why you're asking the questions. I know we've talked about that, but there are some things that I've posted in there that explains like how to talk to them and say like what you're going to do with the information. And there's a little bit of that in there as well. So we have a lot of resources on that page. It has a little password. I'll send that to everyone. And we'll be scheduling a meeting for August, like Natalie said. We can go through everyone's PDSAs, and so we're looking forward to that. Great, and Natalie posted another link in there if you want to copy that real quick. We'll make sure all of this though is on the page, the collaborative page that we have. And we'll get that all up to date in the next couple of weeks and make sure everyone has access to that. So, okay, well, we've kept you a minute over. I know some people probably have 1 o'clock meetings, so we'll let you go. And thanks again for participating, and we will all be in touch.
Thanks, everyone.
Have a great solstice, everyone.
Yeah.
Thank you.
Thank you.
Thank you so much.
Thanks so much.